So let's go to presentation. Are we there? So I'm going to share with you this patient that we saw recently in the clinic at Bradford. She's a lady in her 40s. She presented with blurred vision in her right eye, 3 months duration. The visual acuity is 624 in the right eye, not improving with pinhole. The acuity in the left eye is 6/7.5. She gave a history that she had subarachnoid hemorrhage, an intraventricular hemorrhage, and she was comatose for a while. She required metallic clip to anterior communicating artery aneurysm. When she woke up after 3 weeks being in coma, she found that the vision was blurred. So I'm going to show you her retinal pictures. Then anterior segments were fine. There was no inflammation. Intraocular pressure was good. This is what the retina looked like. As I said, the visual acuity is 624 in the right eye and 6/7.5 in the left. So first question, what are the obvious changes that you see on the retina, if you see any? It's possible, yeah, it's a good differential diagnosis, but the changes you see, do you think they fit in with Tertian syndrome?
Like rot spots.
They look like rot spots. There are a couple of hemorrhages in the right retina, right? Anything else? How do I bring the pointer on the screen here? Can anybody help me? If not, I can see the pointer on the laptop, but it's not projecting here. No. So what do you think of the blood vessels? If you look at the blood vessels, not projecting very well maybe. We can see the veins quite well. Say again?
Some irregular caliber of the veins.
Thank you. Anything that you can see in the retinal reflex itself? There may be possible fluid in the macula. Yeah, it's a good assessment there. In the right macula only or both maculae? Both, right. Okay, I want to point, pointer doesn't work, but if you look at the macula, so you can see that there's some gray shadow all about this area here. Does that look any different to you? Maybe it's not projecting well. Maybe some ischemia. Okay, so it could be ischemic. That's a good suggestion. Prof. Menon, what would you want to do next then? In assessment, when you look at the retina, would you like any other images?
Yeah, I'd like to do a fluorescein and an OCT.
Okay. Before you do fluorescein, anything else? I'll show you fluorescein as well in a minute.
OCT?
OCT. I'm not going to show you OCT, but I'm going to show you autofluorescence. Does that help? So that's blue autofluorescence. And it's quite useful to look at multimodal imaging in certain cases. In particular, this one, you can see there are few areas of hyper-autofluorescence. Is this? That there? Maybe a little triangle coming in on temporal macula. There are few areas of loss of autofluorescence, which are big blobs. So if you remember, autofluorescence gives you good indication of the health of pigment epithelium and the retina related to that. So if you see hyper autofluorescence, that kind of indicates that the retinal pigment epithelium is under stress of some sort. And if you lose the autofluorescence, oh, thank you, that's brilliant. So if you lose the autofluorescence, that means your pigment epithelial cells are probably dying or about to die or dead. All right? And then you can have the masking, which is from the hemorrhages. So other eye autofluorescence is relatively intact. So there's your fluorescein angiogram, Professor Menon. Anything of interest? So you got a fluorescein and ICG. As I said, we tend to do fluorescein and ICG together in Bradford. So disc is a little bit hyperemic, maybe leaky disc, but there wasn't anything obvious to me, neither in choroid nor in retina. Maybe there is slight enlargement of fuzz, if that. So the OCT next. So before we look at the OCT, I want you to look at the picture on the left of the OCT, which is the infrared image of the retina. And what you find there is a dark area here in the right macula that gives you another view of the retina, looking at the color pictures, the autofluorescence, and now infrared. And infrared, if you remember, gives you indication of what is going on at your RPE layer or deeper in the choroid. So that tells you there's something not right in the deeper retina. The other eye relatively looks normal except for one area there. Right? So if you look at the OCT then, it shows that there is the outer retinal problem. In the area of the scan that goes through your dark infrared image, there is a loss of or collapse of the outer retinal layers, especially the pigment epithelium. So what do you think has happened here? Now somebody mentioned ischemia. So if there was ischemia, where is the ischemia? Thank you. So we thought this was a patient who has had choroidal ischemia, and you probably have come across patients with hypertensive retinopathy who have severe shutdown of the choroid as well. Amalric described them earlier on, where you have RPE disturbance with the triangular retinal lesions that you see clinically earlier on. And later on, you see the hyperpigmentation of the retina. And histologically, both outer nuclear layer and RPE damage comes first, and the OCT scan here confirms some of the changes described histologically. I would suggest that if you have the access to multimodal imaging, try autofluorescence and infrared in such cases. Thank you very much.